Sorry.
Well, thank you all for coming. It's my pleasure to be able to introduce you this morning Professor Ed Neuwelt. Ed is a Hoosier originally from Indiana, trained in medical school at Colorado, and trained in neuro-oncology at the NIH, National Cancer Institute, back in the day. And he completed a neurosurgery residency under Kemp Clark at University of Texas Southwestern in Dallas, who's famous for being the neurosurgeon who declared John F. Kennedy dead in 1963. Not Ed, but Kemp Clark. I spent some time in Queen Square in London, and my first interaction with Dr. Neuwelt was as a junior resident. And at that time, he was a real icon. As a resident, we go, and I think we still send you guys to Chicago to the review course for neurosurgical boards. And Ed, I think he used to do that, because I remember distinctly seeing him there for several days giving talks and thinking, wow, this is really cool. A neurosurgeon who's interested in brain tumors and actually doing seminal research in the field. Dr. Neuwelt has received numerous awards, including the Discovery Award from the Medical Research Foundation and a prestigious Javits Research Fellowship at the NINDS. He is currently professor of neurology and neurosurgery at the University of Oregon Health Sciences in Portland. He's been on study section review boards, been multiply R01 funded for well over 20 years, as well as a number of private funding grants for his research. He's done seminal research in blood-brain barrier disruption. You know that as the shrinking of the endothelial cells, allowing chemo to get into the brain. And some of the research he has done both clinically and in the basic world showed, for instance, that patients with primary CNS lymphoma treated with blood-brain barrier disruption, primary form of therapy, had increased survival up to 14 years median survival, much less cognitive problems than those treated with radiation. So that was his seminal work. He's now moved on to treating metastatic disease of the brain. He'll talk a little bit more about that later today at the Blood-Brain Barrier Symposium. And his newest work with a ferromagnetic agent, ferromoxetol, in the treatment of brain tumors. In other words, trying to figure out whether pseudoprogression really is pseudoprogression or progression, which would enable a lot of patients to stay on their life-saving chemotherapy rather than being taken off because it appears as though it's not working. So I wanted to also, before giving the final introduction, remind everybody that the Blood-Brain Barrier Symposium is taking place today in the School of Nursing, Varnes 40-something or other. There will be signs over there in the School of Nursing building, and that will be happening this morning. There will be lectures all the way from 9 until noon, and then again this afternoon, some very interesting really cutting-edge stuff, so I encourage everybody to attend. So without further ado, I introduce to you Dr. Edward Neuwelt, who will be speaking on targeting the blood-brain barrier in neurologic disease. Ed?
Well, thank you, Paul. We're very appreciative of
All right. Blood-brain barrier consortium has
So, thank you all. And so I'm going to talk about delivery of chemotherapeutics across the blood-brain barrier. And I think that the nice thing about what we have in Oregon is we have people like Leslie Muldoon, who I'm going to embarrass, who can work out things in the laboratory and then talk to people like Nancy Doolittle, who's here, and write the protocol and actually get them to happen. And I think it's becoming increasingly difficult in the current climate, I think, in the United States to pursue translational research. And I think that's a shame. I mean, there's so much pressure on clinical production. Obviously, it starts with basic science, preclinical research, phase 1, phase 2, phase 3 trials, and then oftentimes it stops right after the clinical trials and doesn't go to FDA approval. And I'm hoping to show you some examples where we're trying to go that last step. The average distance between two capillaries in the brain is about 30 microns. So Berislav Zlokovic gave me this slide. It's latex injected into a patient who expired, and then the brain was taken away. And I think it's a beautiful example of the vasculature as a highway to delivery to the brain. I always show this slide almost every time I've ever given a talk. It's a slide from Daryl Bigner and Nick Vick in the 1960s, and it's a high-grade glioma. And the key is the only part that is leaky to horseradish peroxidase is right there. So what we see on the scan, with all due respect to the radiologists who say, here's the tumor, and the neurosurgeons who take that little piece out and say, got the whole thing, is that's the tip of the iceberg. And the blood-brain barrier, both in primary and metastatic disease, is consistently inconsistent. And in my view, unlike breast cancer or colon cancer, we speak too much with our heart and not enough with our brains when treating these diseases. These are whole brain diseases. The radiologists in Scandinavia were studying angiography in the late 1940s, and they found when they did angiograms on rabbits, they had a blue dye, I think it was Evans blue, that the brain turned blue after the angiogram. And what they found was that there was an osmotic mechanism that if you pull water out of the endothelial cells but with a hypertonic solution, that you transiently open the blood-brain barrier. That was published in Acta Scandinavica, which is still a significant journal, not quite as significant as I think it was back in the 1940s. And then Stanley Rappaport republished it in Science in the 1970s. And this is a technique that we were interested in trying to convert from the animal models to patients, and we did that when I was in Texas, and then we went to Oregon where we've done most of the work, and now we have collaborators such as our colleagues from Ohio State, Oklahoma, Minnesota, certain other places. We're delighted that Mike is working with Paul to do it here in Kansas City. So this is a image that, if that lesion was on the surface of the brain, you'd call it a meningioma. But primary CNS lymphoma often looks like a meningioma, except adjacent to ventricles. But the interesting thing is, right there, you see the hypointensity on that MR? The next day we injected mannitol, and the tumor didn't grow, but that rind of non-enhancing tumor lit up with the intraarterial injection of mannitol into the carotid artery for 30 seconds, which opens the blood-brain barrier, as well as in the cortex, because in the cortex there's more capillary density than there is in white matter. So, current treatment of primary CNS lymphoma, when we started in this area, was radiation. Then it was radiation and methotrexate. As a young whippersnapper in Texas, and then I took the Oregon Trail to Oregon, we said, this is a problem. These patients are all cognitively impaired. And so we published a paper in Neurosurgery in 1983 saying, well, you can get complete and at that time, at least initially, durable responses by just enhancing the delivery of methotrexate-based chemotherapy with opening the blood-brain barrier. And some of those patients are still alive. So you can, and Nancy Doolittle, as we'll see, has reviewed the cognitive outcome of some of those individuals. So methotrexate-based chemotherapy with reduced dose radiotherapy is now being done, particularly in the Northeast. Induction chemotherapy followed by high-dose chemotherapy with and without stem cell transplant is coming from San Francisco and other places. We're still doing the same old thing. We're opening the blood-brain barrier and giving chemotherapy, and we'll talk a little bit about how we're doing. This is the efficacy slide of our consortium, helped with the colleagues from Ohio State. If the patient's less than 60 years old and has a Karnofsky of 70, that's the red line, the median survival is 12 years. So now if you just give, and there was a paper in Lancet Oncology last year from the Germans, just using primarily methotrexate without Rituxan, the median survival there was like 18 months. So I think delivery and Rituxan are making a difference, and you can get complete and durable responses. And so the issue is the patients are living, and how good is their cognition? Well, we've been obsessive compulsive with regard to doing neuropsych testing since the late 1970s. So all our patients get about a 45-minute battery of neuropsych testing before we do blood-brain barrier disruption. And then Nancy wrote a protocol. We had a neuropsychologist that was working with us, and we put her on various airplanes around the country to test the patients of how they were doing. The longest survivor was this gentleman from Detroit. Was it 26 years, Nancy? And she published this last year in the Journal of Clinical Oncology. And I think it's sort of interesting that, if anything, their cognitive function improved from baseline. Red is declined using a very sensitive battery of cognitive tests. There's not much red on this slide. And so we were very pleased to see that. The median follow-up in that series was 12 years. As I said, they were stable or improved with regard to their cognitive function, their quality of life. One gentleman is an orthopedic surgeon, one is a tax lawyer. They function in society. And then Nancy did another study with our colleagues in Germany, looking at the long-term cognitive function with different modalities of therapy for the primary CNS lymphoma, non-AIDS primary CNS lymphoma. And you can see the red stars are not communists. They're statistically significant outliers who got chemotherapy but with whole brain radiation. And with regard to the cognitive testing, which was done in the same way in Germany, we belong to an international consortium called the IPCG. And the IPCG, the International Primary CNS Lymphoma Group, agreed on this international cognitive testing battery, which you can do in multiple languages. And we were able to get this work due to the help of the Germans and Nancy's work. Again, when you compare high-dose methotrexate with barrier disruption, high-dose methotrexate with autologous stem cell transplant, and high-dose methotrexate with radiation, again, the red with the star is the outliers. The T2 abnormality is greater in those patients, as you'd expect with the cognitive loss, than with the other three groups. So patients with radiation, again, so there's still some discussion whether 2,300 rads as opposed to 4,300, which has been used previously, gets rid of some of this, but we prefer to stay without radiation. So are there any neurosurgery residents? I know there are. So do antibodies cross the blood-brain barrier? Molecular weight 160,000 Daltons, IgM 1 million. What's the answer?
I would say no because they're large.
Who said that? That's absolutely right. Where does the IgM in the CSF come from? It comes from the plasma. There's no lymph nodes or immune machinery in the brain. So even IgM with the molecular weight of 1 million, it's just not very much. And Leslie Muldoon wrote a very nice review article talking about this issue. And part of the reason that it gets in is these antibodies have a plasma half-life of 17 to 20 days, whereas chemotherapy is an hour or two. So everything crosses the blood-brain barrier. It's just a question of how much. And we sort of forgot about that until we started doing some experiments in the laboratory where we saw much more of a response to Rituxan, an antibody to CD20 that's commonly used by medical oncologists outside the nervous system. And we and others around the country have increasingly been using it in primary CNS lymphoma, and people say, you're nuts. It doesn't cross the blood-brain barrier. Well, first of all, the tumor makes it a little leaky, and second of all, it has a plasma half-life of 17 days. It can attach to CD20 cells. It gets trapped, and it has a significant impact. Well, so we looked at recurrent primary CNS lymphoma, and we had a sample size of 37 patients who did not get Rituxan, and there were no 2-year survivals with recurrent CNS lymphoma. Whereas in the subsequent series, this is not randomized, of 22 patients that we treated that we did give methotrexate-based chemotherapy, 3 were alive more than 2 years. So that tipped us off that something was going on. We then looked at it in frontline therapy. Here's the median age, 64. Median Karnofsky, 70. And the overall survival and progression-free survival was better than anything we'd seen before. And in fact, it went from, in our series of 149 patients of our consortium who were treated without Rituxan, median survival, overall survival was 3.1 years, and with Rituxan added to the blood-brain barrier with methotrexate-based therapy went up to 5.1 years. So by adding Rituxan, I think we've made an incremental change. Prakash Ambati has been pushing high-dose methotrexate with Rituxan at Hopkins, and we stole him, made him come west. And so we're trying to decide how important it is. But I think one of the key facts, and as they're doing it at Hopkins and we're doing in Oregon, and Lauren Abre started some of this when she was at Sloan Kettering, is that we think even though there's rarely, the bone marrow biopsies in 95+% of patients with primary CNS lymphoma shows no tumor. But as Christoph Janke, who worked with us for a year or two, published in Blood, by PCR there may be molecular evidence of disease in the bone marrow, and we think the high rate of recurrence in primary CNS lymphoma is there's a slow leak of a tiny amount of tumor in the bone marrow. There's enough immune resistance to prevent it from growing systemically, but if it sneaks into the brain, it may recur. And so Nancy Doolittle, again, has worked out a protocol that Genentech is partially funding, and the NIH, we had it in one of our R01 grants, so we're going to do a randomized prospective phase 3 trial of maintenance after you get a complete response. Our complete response rate now is about 85%, but the key is maintaining that. And since we started using maintenance Rituxan, our recurrence rate has gone significantly down. So that's sort of where we are with primary CNS lymphoma. We don't treat. We tried glioblastoma with blood-brain barrier disruption. We don't have the right drugs. But oligodendrogliomas, who failed Temodar, we recently finished a phase 1 trial of melphalan and carboplatin with IV etoposide. And in the phase 1 trial, you normally don't see a whole lot of responses. The phase 1 trial is made for toxicity, but we had 2 complete responses in patients who'd failed Temodar. And so we're continuing that among our consortium, and the results obviously are much better if the tumors are 1p19q deleted. Now, Mike is going to choke. But this is another area that we don't quite understand. But let me tell you what's happening. I got a telephone call from Canada. There was a young neurosurgeon who trained at the Bordenko in Russia, and he wanted to do some research in the United States, Seymour Gromanov. So he honchoed some of the work that I'm going to show you. So if you get angry about it, you can argue with him. He's not in the room. And it deals with the issue of pseudoprogression, as Paul mentioned. Here's a typical case where the tumor, after conformal radiochemotherapy, gets bigger after 3 months. And then Zhao, where's Zhao?
Here.
We argue every week. And see, I'm over 65, so in our university, I get free coffee. So I bet him a cup of coffee. Progression or true tumor progression. And he wins about 50% of the time, and I win about 50% of the time. But the key is that the blood volume is low. And when the blood volume is low, we don't use the Raynaud criteria. The Raynaud criteria is if it happens a 25% increase within 3 months and then it gets better, then that's pseudoprogression. Well, we've had pseudoprogression up to a year. And in fact, the later the pseudoprogression, beyond 3 months, the better the prognosis. So here's a patient. It was worse after 3 months. 5 months it started to get better. And this patient I need to update because he's 5.5 years out. I've never seen survivals like that. Now, here's an example with cerebral blood volume perfusion imaging and using ferumoxytol. And you can see that there's high blood volume there. So in this case, the increase in enhancement on gadolinium is true tumor progression. But this is what blows me away. So Seymour, who started doing these studies with ferumoxytol in rats, and then Shanad Villarier, who I think not here quite yet, but he'll be here later, did studies in rats, and then we moved to humans. If the patients never had pseudoprogression, I mean, they could have had a partial response with gadolinium, but if they never had pseudoprogression, the median survival of those 68 patients is 13 months. If they had pseudoprogression at any time, some of them up to a year after chemoradiotherapy, as documented by perfusion imaging, either with Nordic ice and gadolinium or with ferumoxytol. In all our protocols, we do both. Their median survival was 34 months. And in fact, if they had MGMT and pseudoprogression at any time, their median survival is 54 months. And they're normal. They're the conformal radiation. We have any radiotherapists in the room? I mean, using conformal radiation with oral Temodar has just completely changed our outlook in glioblastoma. And we're trying to figure out what pseudoprogression really is. And nobody really knows. But we feel, and we're going to talk about that in the consortium this morning, that this is a form not of adaptive immunity, but of innate immunity, because there's very few lymphocytes. It's macrophages and necrosis. And we're trying to figure out how we can try to improve upon that. So everybody else is doing immunotherapy with vaccines. We're trying to figure out what innate immunity is doing in these patients with pseudoprogression. Now let's move on to targeting. I think we're going to, is Bill Timmer here yet? I haven't seen him. He's going to talk about the NIH portfolio in metastatic disease. So I haven't heard the latest number, but a few years ago, there was a meeting of brain tumors. So primary brain tumors, that's where all the money goes. But 10 times more common than primary brain tumors is metastatic brain tumors. And I think that in the entire portfolio of both the Neurology Institute and the Cancer Institute, there was 3 or 4 R01s. I mean, we're not going where the action is. So we've been trying to move out of primary brain tumors, not leave it alone, but and go into metastatic disease. And the problem with metastatic disease is, everybody in this room knows, you can burn them with radiosurgery, or cut them out first and then burn them, or just burn them and then with or without whole brain radiation. But that's sort of the state of the art. So we were intrigued. Roy Wu, who was one of the senior people at Sept, which I sort of call the Supreme Court of cancer care in America, cancer treatment and experimental therapeutics at the NIH, asked us to look at this antibody which Johnson & Johnson had, which binds to alpha V integrins. And they noticed that the antibody was very safe. But they did a phase 2 clinical trial because they thought this was going to be a gangbuster drug, sort of like Avastin. And it didn't turn out to have the therapeutic impact that they thought it would. But they noticed that the patients that got the pan-alpha V integrin antibody in a randomized phase 2 trial didn't get, for melanoma, didn't get brain mets. And so they asked Roy to find somebody to help them with regard to this issue of the blood-brain barrier, and so we did. We normally, and in fact to this day, have maybe 2% of our funding comes from companies. We don't like to behave. And so the expertise of Leslie and Nancy, we've depended on federal grants, which is becoming increasingly difficult with some of the funding cuts. But when Roy Wu calls you, you don't say no. And we studied this antibody. And the two things that it did, it was supposed to be the same as Avastin, but it increased permeability as opposed to Avastin, which decreases permeability. And that was a surprise. And the decreased permeability, and you can see in the middle, bevacizumab on what's called quantitative autoradiography dramatically decreases delivery of molecules the size of chemotherapy. This is as opposed to the inotuzumab, which is the pan-alpha V antibody. The bright green means it increases delivery over controls, which got neither antibody. So that was a surprise. The other surprise was that bevacizumab decreases cerebral blood volume, and inotuzumab actually increased it. So that was interesting too. And here you can see that with Avastin, the blood vessels are a shadow of themselves compared to the controls. But the inotuzumab, the pan-alpha V antibody, these small vessels are actually more plump. So what was predicted to be that have similar pathophysiology was totally wrong. It was opposite of Avastin in every parameter that we studied. And so we thought that was pretty interesting, and as a sort of an intravenous way to increase drug delivery using a pan-alpha V integrin antibody. But what really blew us away was this. Looking at the rate of brain metastasis when you take high HER2 breast cancer cells and inject them into the carotid artery. Because our belief is if we can prevent brain mets, it's much better than trying to treat them when you got them, because that's a much tougher nut to crack. And so we took high HER2 breast cancer cells, injected them into the carotid artery in the rat, and at 11 weeks, virtually every animal had multiple brain mets on MR. Whereas if we gave them intravenous tumumab, the pan-alpha V antibody, the incidence of brain mets was dramatically decreased, and about 30% of them had no brain mets, even if we gave the antibody a week after we gave the intracarotid high HER2 breast cancer cells. So the way I look at it, if I have a little tremor, so if I did a needle biopsy, I'd probably break loose a few cancer cells on my way into that breast lump. And if that came back as high HER2, and you gave the antibody intravenously even a week later after the pathologists who sometimes take their time in giving you a diagnosis, you might prevent brain mets. And so this is an area that we're really going after with guns blazing. This is the histology, and you can see that 8 of the animals never at any time developed any brain mets, and the ones that did develop brain mets were generally 1 to 3, whereas if you didn't give the antibody, all of them had more than 15 brain mets at 11 weeks. So preventing brain mets with alpha V integrin antibodies and other mechanisms is an area that we're pursuing with excitement. The next couple slides are some of the molecular studies that Sanjeet, what's Sanjeet's last name? Lau. It's right there on the slide. We're working with Leslie produced, and it was the effect of alpha V integrin and HER2 expression knockdown in breast cancer cells. And the knockdown of alpha V integrin and or of HER2 decreased the cell migration, as I'll show you, and there was lower integrin expression. The tumor cells also grew more slowly. So here's alpha V plus cells and HER2 plus cells, alpha V plus, HER2 minus. The yellow is the alpha V integrin on the surface of the cell. And if you do alpha V integrin, you no longer see those little beautiful yellow dots on the surface of the cell. And that resulted in a disordered cytoskeleton and impaired cell spreading, as I'll show you. Here we have alpha integrin and HER2 localization. HER2 is localized primarily to the cell membrane. Knockdown of alpha V integrin causes a marked decrease in the membrane HER2, and the HER2 then becomes seen at the lysosome. And while that's spectacular art, but does it mean anything? Well, this is without the knockdown. You can see nice invasive cells, but when you knock it down, you have a very sharp border. So the fact is, it does impact the invasiveness of the tumor. So knockdown of alpha V integrin and HER2 caused cytoskeletal disorganization, and lack of alpha V integrin shunted HER2 to the lysosome, and also had a direct impact on the invasiveness of the tumor. So that's hardcore molecular biology or cell biology. But what does some of this mean to us who are more on the front lines clinically? I'm just going to show you a single case. This is a 42. I have about 15 minutes left.
20 minutes, sure.
Okay, I'll be done easily, I think. This was a 42-year-old woman with high HER2 metastatic breast cancer. She'd had the kitchen sink when she came to see us, and I mean, it was she had 4 children, and she basically wanted to live till Christmas, and we got her to that. We started off with intra-arterial chemotherapy, and we got a transient response. We don't do blood-brain barrier disruption in metastatic disease at this point. We just do intra-arterial. Then she had a recurrence and received a single dose of TDM1. The following images show the pre- and post-treatment MR. So there is the T2 weighted before treatment and after treatment. You can see a lot less increased signal on the T2 images with one dose of intravenous outpatient TDM1. Nice response with gadolinium. But what blows my socks off, and here's the coronal images of FLAIR. Now that's the center of brains right over there. So which resident is going to tell me? This is a perfusion MR with what's called steady state. And the arrow shows you the difference. What is the arrow showing? The vascularity of the tumor with one dose of TDM1, which is an antibody to HER2 conjugated to via an acid labile linker to a toxin that when is internalized is released because it goes to the lysosome, and the lysosome has got a low pH, and so it kills that cell and surrounding cells. One dose, all of the vascularity disappears. And the lady did well for several months, but she subsequently recurred. So we're very excited with antibody-targeted toxin delivery, and it's having a major impact in hematopoietic malignancy, but it's starting to have impact in metastatic disease. And now there's even, in Chicago, there's a company that's made one to the V3 mutant, an antibody to the V3 mutant with a toxin on it. So it's a pretty exciting area, these antibody-targeted toxins. Now, is Kevin still here? Yeah. So were you involved did you treat anybody on the COG trial of sodium thiosulfate? Well, we're here to market it. So what happened was we were studying carboplatin, not cisplatin, carboplatin, as another agent in the laboratory. Because if you give intraarterial cisplatin, even without disruption, the rats don't wake up. Cisplatin intraarterially to the internal is extraordinarily dangerous. That and adriamycin. But carboplatin, which has got more bone marrow toxicity and less neurotoxicity, was very safe. So we did animals. Leslie did animal studies. Nancy did the usual, wrote the phase 1 trial, and we started to see, even at the phase 1 trial, with opening the blood-brain barrier to carboplatin, particularly via the vertebral artery, that we were seeing high-frequency hearing loss. Well, we didn't expect that. So we went back to the laboratory. We did the initial pharmacology and toxicity, but we didn't look at hearing because it was carboplatin. And there was a senior professor, very senior, who was literally walking out the door to be retired. His name was Bob Brummett. And Bob had a model in the guinea pig of auditory brainstem evoked responses looking at aminoglycosides, which causes a lot of trouble, particularly in the pediatric neonatal ICU, of hearing loss. So we asked him if we could try our carboplatin instead of his aminoglycoside in his guinea pig model, and I'll be darned, they had hearing loss, and the hearing loss was just like in patients. It's a high frequency, usually greater than 3,000 hertz, and a patient with ovarian cancer on the East Coast who had a sanctuary recurrence. You guys know what a sanctuary recurrence is? It recurs in the brain and nowhere else. So it's increasingly happening, particularly in melanoma and high HER2 breast cancer. 33% of women, it used to be 8%, 33% of women getting Herceptin for high HER2 breast cancer are recurring in the brain. Oftentimes it's the sole site, and that's a sanctuary recurrence. So this lady had ovarian tumor back in the speech area, so she didn't want a craniotomy. and her husband, who worked in the Office of Scientific Misconduct, looked up on the internet, and he assured us that he did it on the lunch hour, non-government time, and said sodium thiosulfate, which is normally used for cyanide poisoning, can prevent some forms of drug-induced hearing loss. So we got his story from the Office of Scientific Misconduct into the laboratory with Dr. Brummett's help and looked at this issue. And indeed, sodium thiosulfate, up to 8 hours, right there, could completely protect against the ototoxicity. 24 hours sodium thiosulfate after the platinum, no way. And no sodium thiosulfate, you have a lot of cochlear potential inhibition. And we did this with cochlear potentials, and we did it with auditory brainstem evoked responses here. And you can see here, 12 hours, you get hearing loss, but at 8 hours. So most of the platinum in the chemotherapy is gone by 6 to 8 hours. So we had an opportunity to separate normal tissue toxicity from tumor toxicity. And we looked at the two main chemoprotectants that we thought would prevent the hearing loss but not protect the tumor, and that's N-acetylcysteine and sodium thiosulfate. And you can see the tumor response is the same whether you give one or both, but if you don't give the chemotherapy, there's the tumor. So, anti-tumor efficacy in the presence of chemoprotection. We published that 10 years ago. Then again, this is a repeating saga. Nancy did the initial clinical trials, phase 1, finding the dose, and it takes industrial doses of sodium thiosulfate. The normal dose is maybe 1 gram. We had to go up to 20 grams per meter squared of sodium thiosulfate. And the later we gave it, the better the chemoprotection of the ear. And that's because it takes a ratio of 400 to 1 to inactivate the platinum. And so the sodium thiosulfate has a half-life of 9 minutes. And so the yellow is giving it 4 hours after carboplatinum, and there's the least hearing loss after sequential barrier disruptions with carboplatin. So we showed that at a COG symposium about a decade ago. And there was 2 camps in the pediatric oncology group. There was one camp that said, well, that's very interesting, but there's still a theoretical risk that you may protect the tumor and get less impact of cisplatin, which we'd also studied. And the other camp says, listen, if you get mild hearing loss from cisplatin, mild, in a quiet room like this you can hear, but in a classroom you can hear. So the rate of kids failing a grade in school goes from 4%, because in America mothers don't like their kids to fail a grade in school, to 40%. So and those 2 camps still persist. But we persisted, and the Europeans decided to start a randomized phase 3 trial of sodium thiosulfate. And then the Americans decided they would too. And those 2 phase 3 trials were just reported at ASCO this last 2 or 3 months ago. And as we'll talk about on Monday at Children's, the rate of hearing loss, the primary endpoint was otoprotection more than 50%, and it was. But most interesting was in kids under 5. The hearing loss went from a 72% incidence of ASHA, American Society of Hearing Association, hearing loss, went from 72% to 20%. Now, the kicker in all this was we were anxious to get as many patients, and we had patients with neuroblastoma, osteogenic sarcoma, head and neck tumors, ovarian tumors, and medulloblastoma. The patients that had disseminated disease at diagnosis did have a suggestion of tumor protection. And we were stupid enough that all our animal models were localized models. But the patients that had localized disease at diagnosis with up to 7 years follow-up, because these studies started in 2007, there wasn't a twit of tumor protection. So now we have the problem of what to do. We presented this work at our local pediatric oncology Grand Rounds at their request, because the results were shown at ASCO. And the FDA said, well, maybe you ought to do a third phase 3 trial. And so I asked with STS versus observation. And we showed the data, and not a single one of the pediatric oncologists was willing to enroll a patient into that theoretical protocol. So we're having a meeting which you're all invited to in March, our annual Blood-Brain Barrier Consortium meeting. And the head of COG is going to come, who has concerns about giving chemoprotections, and Greg Riemann, who used to be the head of COG, is now the head of drugs for pediatric oncology drugs at FDA, and we're going to try to decide what course we should go with regard to chemoprotection. But you clearly can do it, and in localized disease, which is about 80% of the patients in the COG trial, without any evidence of tumor protection. And there's the second phase 3 trial, which is now basically closed, but again shows no tumor protection in hepatoblastoma. So what I've tried to do over the last 45 to 50 minutes is talk about our translational studies over the last 30 years, enhanced delivery, such as in primary CNS lymphoma, showing not only complete response going up to 85%, but without cognitive loss. I've shown you a little bit of these iron nanoparticles, which we're going to talk about here on Monday at 7:30. Michael, where's that going to be?
It's going to be in the radiology conference room. Radiology conference, yeah.
And then finally the issue of chemoprotection. Now we have orphan drug designation for both the iron particles and the thiols, so we're hoping to get FDA approval for both of these and go the full way across the bridge of translational research. Here's some of our collaborators for whom we're very appreciative. And I can't say enough about the federal government, the VA, the Department of Defense, the NIH, who's made this possible, along with the generous contribution of a grant that I didn't even ask for, from a foundation in Chicago, the Lucy and Walter S. Driscoll Foundation. I have no financial interest in any of this, and we're sort of cowboys, so they put us in this upper floor that used to be the animal care quarters. There's our laboratories, and there's the one portal for breathing air. Thank you. We're delighted that I think it's a done deal, Michael and Paul, that you guys are going to do some of this stuff here, or is it still a negotiation?
No, we're moving forward.
Done deal. Yes, sir. House staff. I like that.
I had a question just as far as a clinical application of this, but blood-brain barrier disruption on like imaging protocols, as far as like primary CNS lymphoma, if giving mannitol prior would give you better images of the tumor for like targeting for a biopsy or something. Versus
what you're saying is absolutely true, but we don't do blood-brain barrier disruption.
Well, what's like
but when you do blood-brain barrier disruption, as Jao can attest, our neuroradiologist guru, who we call him an internist. But on the CT scan, oftentimes the tumor is more prominent and bigger than it is on the MR the night before. Do you have any comments about that?
Yeah, we see quite often. So after the disruption, we always have a regular CT with contrast, and usually what we can see is bigger than the MRI with contrast that was done the night before. And sometimes we can see small lesions that we couldn't see before. So it really enhances any tumor.
Just to know if that like had any clinical application for us, as far as we've had a few recently, even some people we suspect are CNS lymphoma, and we go to do our planning scan or stereotactic MRI to do a biopsy, and they don't have very good enhancement. So we at that point kind of have to make a decision whether we go for a biopsy off of an old imaging versus kind of holding off and doing a repeat scan later. Whereas if we would have given maybe mannitol prior to that stereotactic imaging,
Well, that's pretty invasive. But,
Yeah.
but do they get to come Monday morning?
Yes, you can come over.
Iron will show you the lymphoma much better than gadolinium because it's taken up by CD20 cells. And one of our residents, Brian Farrell, just published those results in 10 patients along with Nancy in July of last year. But iron will help you a lot, and we're hoping to get collaboration here with iron imaging, both in adults and maybe even in children. So we'll talk about that. Michael, do you have a comment?
Well, two comments. One, and I don't know if they saw this, I'll have to go back and take a look at those two studies that got published, but what I've seen also with the sodium thiosulfate is that it can be a bone marrow protectant as well.
Oh, absolutely. Platelets.
Yep. And so people can tolerate chemotherapy much better from a heme standpoint than without it. I guess the other question, and maybe this is for later this morning, but you kind of put the slide up about intraarterial temozolomide, and then you moved right on.
Well, that's a story that Leslie's going to talk about.
Okay.
We screwed up, and we thought we did all the right animal studies, and we didn't. Do you want? Leslie, you want to say what happened?
We did a bunch of studies in rats showing that IA delivery improved Temodar delivery to the brain tumor and improved efficacy in the brain tumor. But then we went back and did toxicity studies, and it was in fact quite toxic.
The rats were walking, but you have to really
Rats can do a lot with
injured brain.
brain injury.
And so, based upon our animal studies, and since it was an FDA-approved trial, we were going to do just a case series of 3 or 4 patients because they were doing it with a tracker catheter in the brain in New York, which we don't totally agree with because it's not a localized disease. So we took a patient who had failed every protocol, and he'd been around the country getting on every protocol he could, and he was still in remarkably good shape. And we gave a modest dose, 100 mg per meter squared, of intraarterial Temodar the first time, and it took him more time to wake up. Not disruption, just intraarterial. And then the second time, within 30 seconds, his pulse went from 80 to 200, and his blood pressure went from a systolic of 90 to 210. So we immediately stopped, and he got a little bit of rash on his upper chest. We immediately stopped and we went back to the laboratory. Well, what we didn't do, so we'll see the data, because Mike has been very interested in this. When we opened the blood-brain barrier with Temodar, we never saw a rat wake up. But if we gave it intraarterially, as Leslie said, the rats were fine, and there was tumor efficacy on MR. But what we didn't do is check the blood-brain barrier integrity with just intraarterial Temodar, because it's got a diluent in it. And we thought the diluent was the problem. And it turns out it wasn't. It's probably the low pH, because it's hard to get it in solution. So what we thought was a very safe approach, we almost killed somebody. So I don't recommend it. But you'll see the actual data in a couple hours. Even every other year in July, we call it the July syndrome, the heart stops. So what happens? Well, the new anesthesiologist says this patient doesn't need as much atropine to block the carotid body. And so then they get it asystole, but by the time I walk in the room, then it started again. We've done this 6,000 times, and we have, I think, 1 treatment-related death. So, I mean, if you do it right, it's safe. But if you don't follow the protocol, and then they come up with other new drugs that the anesthesiologists want to use, they like to do French cooking. And we say, no, unless you want to go in the lab and try it, because lots of things. We have one guy in this city who had obsessive compulsive disease that we were treating. So we had to, every month we took him off of lithium. He went nuts. So we said, well, lithium is sort of like potassium, and let's just not take him off the lithium. So we opened the blood-brain barrier, and we extubated him 2 weeks later. It was a complete response from Kansas City. Any other questions? Mary Kay.
Ed, with your metastatic disease model, do you have any model yet of a systemically implanted tumor to see whether giving the integrin antibody would be helpful in prophylaxis against developing METs? Do you have a model of, flank tumor or whatever that mets to the brain that you can study that question?
I'll let Dr. Muldoon answer.
Mary Kay, we have not done those studies, but a researcher at San Diego has done both memory fat pad breast cancer and subcutaneously implanted breast cancer. And the intutumumab does block both of those from metastasizing, but they didn't look at brain mets.
They did not look
They
at
did not
brain.
look at brain mets, they looked at lung mets.
But we did.
Okay, have you looked at
We have not done any
of that to look at the brain?
any
Okay.
tumors outside of the brain.
But we inject the cells into the
But, yeah, I
carotid.
understand that part. I'd be curious. It's too bad they didn't look at
Yeah.
the brain.
We call them up. Do you have the brains from those studies? I don't know.
I mean, sub-Q models are terrible because that's an avascular space. So we avoid subcutaneous, but others, such as the fat pad, I think is a more reasonable model. Good question. Okay, I think we're done.
Thank you, Ed.
Thank you.